Okay, we're going to go over communication and documentation in here. All right, so communications and documentation, we're going to go over this. I'm going to tell you all kind of some of the highlights of what I want you to study in your book. By doing this now, I really want y'all to help your classmates get the word out that I've got this lecture online. We've got a 3-day weekend. This is going to stop the snowball from getting bigger just due to how these past couple of days has gone, like we talked about this morning. All right, so here we go. All right, hold on one second. Let me adjust myself out of the way a little bit more. Okay, so therapeutic communication. All right, so we talked a little bit about how we should talk to people, stuff like that, and wellness, and I tied a lot of this uh, communication stuff in to the what I did this morning before lunch. So there's a lot of factors that we're looking at whenever we go into education, communication, the culture, person's age, what we're judging their body language as, eye contact, facial expression, voice tempo, all of that. Okay, so if you think that going up to an elderly person
and speaking to them like this is okay, then you are sadly mistaken.
So really, therapeutic communication begins with it just being authentic and going off of the principles of what we spoke about earlier today. So looking at, age, culture, all of these things are going to influence how someone communicates, right? Um, Body language and eye contact are also, pretty well em- embedded in culture. So, you know, you can go to one area where it's expected to be making really, really deep eye contact whenever you speak to someone, or you can be around certain more high crime areas, gangs, stuff like that, where making eye contact is, a sign of you're testing someone's dominance or you're posing a threat to someone, and you can get a very different type of reaction to it. Additionally, if you have the neurodiverse type of person, uh, being forced to make eye contact can cause a lot of anxiety. So, people with ADHD, autism, stuff like that. If you're trying to force eye contact or chase somebody's eyes around, you're causing a lot of anxiety, and that's not going to create a therapeutic type of communication. Again, there's a tone, a pace, a volume, all of these different things, right? So whenever I'm teaching, I'm generally a little bit more faster paced, things like that. Whenever I'm with an adult who's a patient, I may be a little bit slower. I'm kind of judging, their level of understanding of what's going on with them. Whereas, I may be with somebody who is a little bit younger, and, I will sort of change up the way that I communicate with them to sort of meet how they're communicating with me. I stay very fluid with that so that way I can make that patient as comfortable as possible. But here's the main thing: never force your own values onto someone else. Okay? Never do that. All right? That is not what professionals do. If you have something in your personal life where you're doing things, whatever, with, something culturally cool, that's your personal life. Professional life, you can say that we are like culturally agnostic, to where we just need to stay professional and not impose any of our own feelings or biases towards someone. Again, there's nonverbal communication. So, you're sitting back, you're thinking, you're like this, right? How is that looking compared to, making some gentle eye contact? I'm a taller guy, if you're a bigger person, you may be intimidating to some people. Um, and so I try to, just kind of make myself kind of small and, very, approachable, if you will, whenever I'm talking to patients. Again, more nonverbal communication. So you could have patients that, are trying to fight you. They could be trying to fight you for a medical reason or for behavioral reasons. Who knows? The main thing is that you want to try to just stay calm. Remember, they don't know you. Nobody's trying to take this thing personal now. You do know the patient, they're trying to fight you. That's a different story. But, don't assume any type of aggressive posture or anything like that. We're not trying to fight patients. We're going to talk about, restraints and stuff like that later on. Again, it's, maintaining that professional demeanor, not showing the fear, anxiety, anger towards someone is really going to help you whenever it comes to defusing situations. Um, Sorry. All right, we got a visitor, so bear with me. Um, really, this really goes out to a lot of the neurodivergent community. Try to limit the amount of sensory input that you're putting into these scenes. Loud radios, loud talking, trying to talk over people, noise, um, red lights, all of this stuff. Try, if you see that someone is being really uncomfortable, you can tell that they're having some sensory issues, really try to help mitigate that for them and make them as comfortable as possible. And sometimes that's as simple as saying, what can we do to make you more comfortable? Okay, so here's some of these golden rules. All right. So, I don't really agree with all of these because they're kind of subjective. So you don't have to make and keep eye contact all the time. That can get kind of awkward. Also, using your name is really important, right? So coming in and saying, "Hi, I'm Harrison," right? Um, and also use the patient's proper name. So it's pretty easy to judge once you do it for a little bit, whether you need to be a Mr. or Mrs. or, a first name type thing. There's different levels of comfort, right? Sometimes, being super professional, Mr. or Mrs. type of thing can be um, a little over sterile whenever the situation dictates something a little bit more um, loose or relaxed. Um, what you don't want to do is do the "oh honey baby sweetie" type thing. No, that's crossing a line. We don't really need to do that. Try to use languages that the patient can understand. So that means, not explaining to someone that they're having a bunch of medical term. Instead, break it down for them to where they can understand, and then ask them if they understand or if you need to explain anything even more. And then also watch your body language. All right. These all are looking okay here. Speak slowly, clearly. If the patient's hard of hearing, don't just sit there and yell at them as loud as you need to yell. Oh wait, I got a noise limiter. Sorry. Don't yell at them. Okay. Just face them as best you can, right? Because if I'm hiding behind Delaney's head here, can you hear me as well as you can if you can see my lips? Okay, so that helps a lot. Also, just slowing down and asking the patient, hey, how could you hear me a little bit better? And then also maintain your confidence. All right. When someone's really hurt, they can tell if you don't know what the hell you're doing. So fake it till you make it is like your minimum standard. Okay. But really try to be confident in what you're saying to these patients and additionally what you're doing. Emotional intelligence, there's some terms and stuff through here I'd like you to look through your book and really try to, get a good grasp on. All right. So this is just how, you're going to be able to assess and react to stressful situations. We talked a little bit about this this morning, so I'm not going to spend too much time on it. The main thing is that if you can build your empathy where you can learn how to, put yourself in someone else's shoes, then with that, you're going to be able to have a higher level of EI, or that emotional intelligence. All right, so there is a stairway model here that does show you some good things of how you can build a rapport based off of emotional intelligence. So this is a stairway model. It begins with active listening and then goes into empathy, building rapport. And then you can start, influencing a patient, hey, I really think you need to go to the hospital. And then hopefully be able to elicit a behavior change from there. All right. And then when it comes to communicating with children, funny enough, I got a test subject here. All right. So what are some consideration? Oh, there's seniors in here too. What's a consideration whenever you're dealing with seniors? All right. I want you to kind of think about that. And then also, what are some considerations when you're dealing with children? So obviously, a lot of these can kind of go hand in hand. It has to do with, how you're breaking things down, looking at the senior. Don't just assume that they can't hear you or assume that they don't know what you're talking about because they have dementia or something. Really try to take and make a point out of this that, go off of their energy and their level of understanding and adjust yourself accordingly. Now, with these little guys, obviously, Delaney here is not going to be able to understand exactly, what I'm trying to say or even what I'm trying to explain that I'm going to do. So that's whenever I make it silly. I may try to break it down the best I can of, trying to go back into that stairwell to where I can build a rapport and earn the trust to be able to, influence and things like that. So children obviously can take a lot more time to earn their trust, and that's where mom and dad can come in handy. We talked a little bit about that this morning as well. But here's just some, overall stuff here that is pretty relevant. Be professional but friendly, be honest. If you're not honest and you're trying to BS a patient, they're going to lose your trust and then, it's lost. Here's what I like. Maintain eye contact, but don't force it. All right. Position yourself down at their level. The last thing you want is me to be, standing up above her, looking down at her talking, right? That's super intimidating to a 2-year-old. Modesty is important, right? For both children, adults, seniors, unless they are actively dying, we want to do everything we can to maintain their modesty. For her, there are comfort items. Who's this? Is this Mimi?
Mimi.
Mimi. Right? So this is Mimi, okay? She is very comfortable whenever she has one of her 18 million Mimis around her. So it's pretty easy for me to look around, or you come to my house to treat her and you see, oh, there's a shit ton of Mimis here. I bet you she likes Mimi. There you go. Other special population information here. So, what are some things about, hearing impaired patient, visually impaired, non-English speaking, things like that. So all of that really comes into thinking outside of the box, right? So if you have someone who's deaf, what do we carry around? Well, y'all don't carry them around, but, once you get out of recruit school, what are you carrying around? You've got this, you've got notepads that you can use, all of those different things that you can use to have a communication preference. And then the person who's hearing impaired may actually already have a system that I've walked into places where they hand me a, little mini dry erase board about this size, right? That you can write on. Visually impaired, again, don't be one of those who raises their voice to speak louder to someone who's blind. It doesn't work that way. All right. So again, when someone's blind, you're really going to want to explain what you're doing very well. Remember, they can't see it, so you have to be very detailed about that. Non-English speaking, Google Translate is my best friend. Okay. for really, 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 and I reserve this for life or death situations, but the AI translators, things like that, can also come in handy too. Whenever the situation's really important and you need to have a little bit more of a fast conversation. All right, so we're going to switch over from this interpersonal communication. I want to talk to you more about communications, okay? Whenever it comes to how we're talking over a radio, stuff like that. There is a shared mental model that I should discuss here as well. So, you know, this is, I guess, a little bit more interpersonal as well. So this is where the picture that a person has in their head of what's going on. So if you're riding a call with me, I've got a pretty clear picture of what's going on, whereas you, not having as much experience, maybe a little bit more cloudy. It's my job as the one who's in charge to tell you what's up here, what you need to know, and what your jobs are going to be, and vice versa if you're leading this situation. I want y'all to remember this from when you start doing scenarios and somebody's the team leader. Remember, nobody can read your brain. If you can, let me know. We're going to figure out how to make money off of it together. All right, but you've got to be able to paint this picture to your team as to what you want going on. This is something that's very difficult to learn in stressful moments. All right, so really here's some questions you can answer about patient care, right? What's our kind of shared priority here? What's the history of, you know, any care that's been done? What's the current state, right? And what are the immediate needs? These are things that if you're a team leader, you need to communicate out. Additionally, this is going to be important whenever you're doing handovers. Thanks, Delaney. Handovers are really important whenever you have a paramedic or a higher level of care coming on scene, or you have, let's say you're transporting the patient during your field internship and you're going to be taking this person to the hospital. You're going to give this handover report to a nurse or even a doctor sometimes. They could be intimidating. So this is where it's really important, but we don't want to be long-winded. We'll talk more about it because guess what? We're going to practice it. All right. You're going to be doing this a lot, so you're going to be really comfortable with it. So here's some important things. You want to make sure that, you know, eye contact at this professional level is important, so that way you can gauge the level of understanding from this other provider. Make sure that you're trying to manage the environment the best you can. If the paramedic's coming in to a really like kind of chaotic scene, what you'll see is the captain is going to walk out and they're going to try to give this report to the medic as they're walking up to the house where it's a little bit more controlled. All right, so here is a really structured style verbal handover report that we're going to use, the SBAT. So that's the situation, the background, the assessment, and the treatment. This will be the expected format that you will use for all of your handover reports during our class. We're going to do some exercises with this Tuesday morning. But if you see some scenarios in your book that you can read over that kind of show you like, okay, this stuff's going on with the patient, you can go ahead and kind of start crafting that in your head. And I believe there is some information about this type of structured report in your book as well for you to look over. So really what you're going to be looking at is what's the condition, what care has been done, what's the current state, what needs to happen. The chart method. So this is what we're going to be used whenever we write narratives about our patient report or our patient care. So we still have to make reports like you learned about with Captain Mac with your documentation and things like that. Or I'm sorry, it may have been in your online part for this chapter. I'm sorry, little distracted. The chart method is going to be the standardized method that we're going to use for all of your documentation. And what that stands for is the patient's chief complaint, their history, any assessments that you did, like vital signs and other physical assessments, what treatment you provided along with any medications, and then the transport disposition. You may see some other SOAP. You may see this in testing, either EMS testing or the state test. So it's just a good one to know what that means. But at the end, all narrative sections should contain the minimum of this, right? What time it happened, any assessment findings, what emergency care you provided, changes in the patient after treatment, both good or bad. Remember, we're not hiding anything here. Any observations that you may have seen, drug paraphernalia, signs of neglect, abuse, so on and so forth, any refusal of care, and, the person that you may have handed this care off to. You teaching them? Yeah. All right. Reporting errors. Like I mentioned it earlier that, we may have errors with patient care that we need to document, but what happens if you, I don't know, make a mistake on your report or choose to leave something out with omission, right? So if you leave something out or record it incorrectly, do not try to cover this up. What you are writing are legal documents, okay? Falsification is punishable by law. You do not want to do that, okay? So, obviously, that's true. It can result in suspension and legal action. So if you make a mistake, the proper way to do this is what you can see here in this picture. You draw a singular line through it. You don't go crazy scratching it out. Single line. Initial at the top, and then you're going to write the correct information next to it. I expect to see any handwritten reports that aren't done through Platinum Planner, which I'll talk to you about next week. Any handwritten reports that you do, if you make a mistake, I expect to see that done that way. All right, again, draw a single line through it, initial it, write the correct information. Documenting refusal of care. This is something that a lot of EMS is going to be taking care of, but it's something that I want you to know. This is pretty important information that you will be tested on, both EMS testing and state level. Very common source of lawsuits. So if a patient refuses care, also refuses transport, the document, you have to document everything, including like what you told the patient as to why you think they should go to the hospital, et cetera, et cetera. The patient has to sign a refusal form, and then it's best to have either a lot of times you'll be asked as a firefighter or if there is a law enforcement officer on scene, EMS will generally ask that person to. The police officer is kind of one of the best, then we sort of fall into second, then family member comes up thereafter that. And then you're still going to complete the PCR, that pre-hospital care report. There are some, required mandatory reporting situations. So, these can be dog bites, infectious disease information, but here's kind of one of our big mandatory reports: physical or sexual abuse as well as neglect, both towards elders and children. There may be some other things that come up, but the main one that you're going to have to worry about is physical or sexual abuse as well as neglect. That's the one you're going to see a lot. Okay. Here's the radio systems. All right, so a lot of this was in your online stuff for this chapter. So I'm asking you right now for you to stay out loud and wherever you are, what is this? This is a base station. This is what you're going to find where? Well, inside the base, of course. No, this is what you would have as like a main radio inside of a structure. That structure could be temporary or permanent, but this is going to be the main one. It has a transmitter and a receiver all built into it. What is this? This is a mobile radio. This is a vehicular mounted radio. This is what you're going to see above the captain's seat inside of our trucks. Now, what is this? This is a portable radio. And where are you going to find it? Well, I was hoping I could do this in class so I could be a smartass, but I'm not. It's behind you on the chargers. So there on the podium side of the room at the very back, all those are portable radios. And then you have repeater-based systems. So what is a radio repeater? Well, that's where you have a radio transmission that goes up to a repeater, and then it comes down to the ambulance. All right, so this is going to let us increase our distance. Something that Guilford Metro is going to, and most other counties already have, is a statewide radio system called Viper. This is the Viper system, and these are all of their repeaters throughout the state. Okay, so it's a statewide system. We could take our radios. It's a whole lot more complicated than this, but this is just the simple answer. We take our radios and we can go down here to the Outer Banks, Bodie Island. This is probably Hatteras, nope, Kitty Hawk, and be able to use our radios perfectly fine, just like we were here. I'm gonna guess that this is up close, Winston. Up here in Greensboro, Triad Park, up by Kernersville, Winston-Salem State. Yeah, Greensboro. There it is. All right, Reedsville, all that. There you go, Greensboro. Okay, so remember, Federal Communications Commission, you might see a test question about that, shows up, and they're the ones who are allocating these frequency. They're monitoring radio operations. Please remember that everything you say on these radios, regardless of what channel, the easiest way to put it is that you are being recorded. So all of these things, you know, can be good to defend you or can also be used against you. So watch what you say on the radios. Oh yeah, so there she was. All right, and then there's also communicating with hospitals and medical control. So remember, we have a medical director, and then we also have, which you should have seen a picture of Dr. Gim earlier, but we also have medical control. So our medical control is Moses Cone Hospital. If you're in High Point, it would be High Point ED. But medical control is there's online and offline. Offline is, guess what? These, your protocols. Online, though, is where you would call over radio or phone into the emergency department and speak with a physician directly. So if these protocols do not answer your question or there's not one, guess what? There's already actually a boom, patient without a protocol. There's a policy for everything. So anyone requesting EMS services will receive a professional evaluation, treatment, and transportation in a systematic, orderly fashion, regardless of the patient's problem or condition. So here's the procedure. Treatment and medical direction for all patient encounters, which can be triaged into an EMS patient care protocol, is to be initiated by that protocol. I.e., somebody says, my chest hurts. Okay, cool. Insert the chest pain protocol. Now, if there is something that does not fit into a protocol, it can happen. It is extremely rare. You will follow that universal patient care protocol that we talked about earlier, but then also your online medical control physician should be contacted as well. All right, so there's also things called encodes, which is going to be a radio report. That's a down. You given a radio report? That is a down and dirty version of that handover report. All right, so here's an example off the top here. Medic 11, we're inbound non-emergency traffic, 45-year-old male complaining of substernal chest pain radiating into the left arm. Vital signs are blah, blah, blah. We gave the patient 324 milligrams of aspirin and 0.4 milligrams of nitroglycerin sublingually. Patient responded as blah, and we'll see you in 5 minutes. That is a very quick radio encode. All right, there you go. So commonly includes the following 10 elements. So, whoops, your unit identification, any, special alert. What that means, code stroke, trauma code, code sepsis, stuff like that. MIs, myocardial infarction, heart attacks, things like that. So, you're going to be, obviously calling Moses Cone, and then your estimated time of arrival. You're going to give the patient's age and gender, but not their names, right? We got to worry about HIPAA. And then the patient's chief complaint. I meant to go over HIPAA whenever we talked. Well, I talked during the first video, a little short one I made about legal. Remember that if you provide any sort of medical care whatsoever, just assume that that patient's any information from that is protected. Yes, it's a lot more nuanced than that, but just assume that, and you'll always be fine. If you want to know the nuancy stuff, talk to me after Academy. Be happy to tell you. All right. There's that offline, online. Really, and to be realistic with you as a Greensboro firefighter, you're not going to be doing this. All right. I'm just going to be straight up with you. You're not going to be doing this. You may see it in field internship, but until something changes, you're not going to be doing this. If it does change, you're going to receive continuing education about that. Again, role of medical control. Ours is Moses Cone ED. It is a physician that's going to be working at a receiving hospital, because guess what? They're going to be receiving the patient that you're calling them about. So yeah, they have, all the authority they need to make those orders, and you can't just call Dr. Gim. All right. Most of the time this is done over radio, but again, there are other options as well that EMS has. Get precise, important information, plain English. Don't want to use codes. If you do get an order from medical control, you say, hey, medical control, I got this. What do you want me to do? Okay, I want you to deliver an additional 0.4 milligrams of nitroglycerin. Call me back if there's no relief and you want to give the patient more. Copy. I will deliver an additional 0.4 milligrams of nitroglycerin, and we'll call you back if there are any complications you want to give me more, right? Simple as that. But if it doesn't make sense, be like, hey, your radio broke out. Can you repeat that? And then ask clarifying questions if needed. At an EMT level, that really shouldn't be happening. So this is your communications overview. Tomorrow, Saturday, I'm going to do a medical terminology lecture and roll it out. All right. Hope y'all have a good night. Delaney, can you say night-night? They're in there. Can you say night-night? Okay, she says good night. Bye-bye.